Thank you, the Center for Medicinal Cannabis Research, for organizing such a stimulating conference. I am Lucile Rapin, Clinical Project Manager at Saftey Cannabis, a clinic and center for research on medical cannabis. Today I'll present you findings from our ongoing observational study of safety and effectiveness of medical cannabis. The presentation is titled Safety of Orally Administered Cannabinoid-Based Medicine, Findings from Clinical Practice. And this was done with Dr. Arboleda, Erin Prosk, Dr. Wattier, and Dr. Dworkin. First, I'd like to disclaim that all authors have a relationship with Saftey Cannabis, a medical cannabis clinic and research center based in Montreal, Canada. Saftey Cannabis operates with the public healthcare system. Patients do not pay fees to receive care at the clinic. Saftey Cannabis does not sell or receive financial benefit from the sale of medical cannabis. This research was funded internally by Saftey Cannabis Clinic. As an introduction, existing evidence points towards a favorable safety profile of cannabinoid-based medicine, with common adverse effects likely to be mild, such as somnolence, dizziness, and dry mouth. Despite the growing popularity of CBD wellness products, severe adverse effects can occur with CBD as well as THC-based oral products. Furthermore, the safety of CBD is generally assessed without consideration of its common combination with THC. In this study, we investigated adverse drug reactions and cannabinoid profile reported by patients taking oral CBM under direct medical supervision. As for the methods, this is an observational study. Specifically, between July 2020 and October 2021, 1,993 adult patients consented to the study and were authorized to receive at least one cannabinoid-based medicine oral product at our network of 4 medical cannabis clinics. Patients coming to the clinic are predominantly referred by their family physician or specialist after not responding to conventional symptom management. Diagnoses are established prior to referral and confirmed by the referring physician. Eligibility for CBM and the corresponding treatment plan is determined at the discretion of the clinic physician based on individualized clinic assessment. CBMs are added to the patient's current regime of prescription medication as a complementary treatment. Participants did not receive any compensation, and enrollment in the study did not affect their clinical care. The study was approved by the McGill University Ethics Committee. Exclusion criteria included current pregnancy or lactation and current psychotic disorder. Data was collected as part of our standard clinical procedures during the initial and a 3-month follow-up visit and extracted from electronic medical records. Adverse drug reactions were systematically collected after the initial visit and included details on ADR terms, severity, causality, outcome, seriousness, and the details of the suspected product. Association between 2 categorical variables was assessed with chi-square test. Now for the results. Out of those almost 2,000 patients, 510, so about 24%, reported a total of 858 ADRs associated with oil products. Almost half of adverse drug reactions were reported at the 1-month follow-up visit and about 30% at the 3-month follow-up visit. The majority of ADRs, about 70%, were evaluated as mild, 26% as moderate, and 3% as severe. 70% of ADRs were recovered or recovering, and 22% not recovered at time of data extraction. Overall, dizziness, headache, and somnolence were the most reported ADRs. There was a significant association between headache and palpitation and the product profile. The proportion of those adverse drug reactions was significantly higher with CBD-dominant products than expected. The patient who reported at least one ADR did not differ from those who did not in terms of age, sex, and CBM cannabinoid profile category. 4 serious ADR were reported that led to a hospitalization. Pulmonary embolism assessed as unlikely related to a CBD dominant oil. This SADR was recovered and treatment was interrupted temporarily. Second, tachycardia probably related to a THC dominant oil. Patient was also taking a CBD rich oil. This serious adverse drug reaction was recovering at time of data extraction, and the THC-rich treatment was interrupted completely. Third, vomiting possibly related to a CBD-dominant oil and a THC-CBD balanced inhaled dried flower. This SADR was recovered at time of data extraction, and treatment was ceased during the day for this patient. Finally, nausea and diarrhea was the fourth SADR that led to a hospitalization, and this was probably related to a THC dominant rich oil. The patient was also taking a CBD rich oil and a THC CBD balanced oil. This SADR was recovered at time of data extraction, and THC dominant treatment was interrupted temporarily. As a conclusion, this study showed that about a quarter of patients reported at least one adverse drug reaction during the study period. The majority were mild and produced by both THC and CBD, in line with previous reports and systematic reviews. As a standard clinical practice, CBM were added as an adjunct to the patient complex makeup of concomitant medication, making causality assessments more challenging. The most frequently reported ADR were dizziness, headache, somnolence, and fatigue. While CBM are generally safe, the study showed that a significant of adverse drug reaction, including serious one, can occur even with a controlled conservative supervision of treatment, initiation, and titration. Like any other medication, medical supervision by fully trained healthcare professionals is required to ensure appropriate follow-up of cannabinoid therapies. Controlled data collection and analysis from dedicated cannabis clinic where high volume of patients are seen provide an excellent opportunity to improve understanding of the safety of cannabinoid-based medicine to determine clinical guidelines that are representative of current medical cannabis product. Thank you very much for listening to this presentation. I'd like to thank all our patients who consented to participate in our observational study, as well as all my colleagues who helped on this study at Saftey Cannabis. If you have any question, you can reach me. My email address is lrapin@safteycannabis.ca. Thank you.